Welcome to the AUANews Inside Tract podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
Thank you for listening to AUANews Inside Tract. My name is Raman. I'm chair of the Department of Urology at Penn State Health and former chair of the AUA's Office of Education. Today, in honor of Prostate Cancer Awareness Month, we're diving into a bold and transformative movement in men's health called Man vs. Prostate. Joining me is Dr. Kuang, urologist, innovator, and founder of the Man vs. Prostate campaign. Dr. Kuang is leading a global call to action to rethink how we approach BPH, benign prostatic hyperplasia, bladder health, as well as the over-reliance on medications. Wayne, as I said earlier, it was delightful getting a chance to meet you in person around a year ago this time. And really a big thanks for joining us on this program today.
Well, thank you for having the Man vs. Prostate campaign come on and join you guys. With a big thanks to Corey Del Bianco and the AUA and AUA Foundation. I think that together, this is what it's going to take. It's going to take this kind of dialogue for us to evolve forward BPH, BPO care, which also has an impact on your world and prostate cancer patients as well. And together we can do this.
No, that's great. I'm really looking forward to this. And so maybe I guess I would say, just as a starting point, maybe give our listeners a little bit of a sense of who Wayne Kuang is. Like, what, where do you practice? What is your practice like? And then maybe we can dive into a little bit more on the campaign itself. But I think it would be really helpful just for folks to get a perspective of who you are.
So, practicing urologist for 19 years now, almost 2 decades. And I finished up my residency and fellowship at the Cleveland Clinic with a fellowship in infertility and andrology. And now initially working predominantly in a LUGPA. Over the last 11 years, have now been in solo practice, really specializing in men's health, and now practice in Albuquerque, New Mexico.
That's great. That's great. So I love the term man versus prostate. So I think if you can think of a catchy term that's sort of all encompassing, I love it. Talk to us a little bit about the origin and the inspiration to start this movement.
I think it's really important, especially for young and rising urologists, to recognize that we're always researchers. We're always academicians with qualitative research. We're always observing patients and patterns. And for me, the index patient for this campaign, it was the fall, one of those cool fall days in New Mexico, October-ish, 2006. I was fresh out of fellowship and I thought, oh man, I can go out and help transform lives and make a difference. And this 70-year-old cowboy kind of walks in begrudgingly. He's escorted by his 2 daughters and 1 son, and they have dragged him up from his ranch from the Gila Mountains in the southwest of New Mexico because they have watched him slowly delaminate, reduced to just the fraction of the cowboy strong father figure that he used to be. And it was all because of his lower urinary tract symptoms. Up every hour at night, urgency, frequency, constant pressure, absolutely miserable. And he was here to see me for a 4th opinion. For every doc, it was, hey, take an alpha blocker or a higher dose or another 5-alpha reductase inhibitor without any diagnostics. And I think he was, just to paint a picture, leathered hands, weathered face, beat up cowboy hat, faded denim jeans, and like these cowboy boots that he must have had for 50, 60 years. So we do a prostate ultrasound, and his prostate is 200 grams. And at that time, 2006, New Mexico, the most I could offer him was an open, simple prostatectomy. And when faced with either continuing to live this miserable life or undertaking the risks of a major open abdominal surgery, he chose the preferred path that he could control, and tragically, he took his own life. So that was the index patient, and it really underscored that there was a certain start of some cognitive dissonance that I was feeling, which was then built upon by every time you go into the emergency room, even for you, Dr. Raman, right? When we were in the residents, you go to the emergency room for a guy in retention. How often were those guys maybe on an alpha blocker or a 5-alpha reductase inhibitor? Many of them. Once again, is there something we're doing wrong? Is there something we could do better when that next patient comes in who's now having to endure the shame and embarrassment of leaking down his leg? That's not okay. So once we started building upon that, we started asking questions like, hey, is there something we can do better? How do we evolve this forward? And this quickly recognized that it wasn't just a local problem or a national problem, but some of my work with IVU, right, and GSE, Global Surgical Expeditions, it's happening all over the world, whether seeing it in Mongolia or Belize. And it's an international problem. And we needed to start thinking about how do we make a small change to have a big impact? And that small change is just a simple thought. Bladder health matters. For an organ that's non-transplantable, other than the brain, the bladder is the only other major organ that we cannot transplant fully functionally. As a result, we need to take better care of it. And so this kind of grew during the pandemic. I had some more time, obviously, as my practice struggled to keep going. And I just wrote an ebook, conversational, community-based conversation about the 5 stages of bladder health. And we can dive in that later if you'd like. This got picked up on LinkedIn. So I just started a conversation on LinkedIn, my first social media experience ever. And the editor, defender, Dr. Luca Cindolo, an editor for Prostate Cancer and Prostatic Diseases Journal of Nature, picked it up and he wrote an editorial saying, hey, maybe this is something we need to think about. And then that kind of ballooned into a talk at the Society of Benign Prostatic Diseases, where the president of the Sociedad Colombiana de Urología, Milton Salazar, who we both know, saw me speak and said, hey, this is a conversation we need to be having internationally in Colombia. And so that's actually how I got to meet you, is he had invited me to give a quick keynote about this for his BPH section. And then now it's kind of grown from a tiny whisper to a collective voice on 6 continents. We are now having this big dialogue, and now we've come out with our second book on Amazon this April, talking about preserving bladder health for BPH.
Oh, that's great. Really amazing. Kudos to you. Obviously, in not only the thought, but obviously the time and the motivation and the spark to sort of start this conversation. So you've described the campaign as a tribe of detrusor, or defenders of the detrusor, right? A tribe of defenders of the detrusor. What does that really mean? And so maybe dovetailing with that, who's the campaign really for?
It's for everybody. It's all inclusive. Anyone or everyone who can embrace this concept that bladder health matters. The bladder is worth defending. I'm so grateful for the defenders of the detrusor for putting up with all my alliterations, but it makes it a little bit fun, and you have to be playful to be a defender a little bit, and you have to have a great smile and take a little positive energy, because as we all know, the world's getting dark and developing shadows, and we need to have that collective effervescence, that collective energy to shine some light into those shadows. And defenders stand together, shoulder to shoulder, on the battlefield of male LUTs. APPs, physical therapists, med tech industry, pharmaceuticals, clinical staff, administrators, residents, rising urologists, academics, community docs, primary care, as well as our patients and their partners. They can all be defenders of the detrusor, because a tsunami of male LUTs, BPH, BPO is already arriving on our doorstep, and we're not talking about it. I mean, think about it. We talk about colon cancer screening all the time, 1 in 23 men, prostate cancer, 1 in 8 men. But what about bladder health that affects 1 in 3 men who are 65 years or older with moderate to severe LUTs? And that's not even accounting for the guys less than 65 that we need to help as well. And that's going to calculate out to about 280 million men by about 2050 worldwide. And there's simply not enough urologic providers to address this issue head on. And so our mission is quite simple. Hey, let's empower these patients with BPH, BPO with the healthcare experience to make the best decision about their prostates even faster by highlighting that bladder health is at risk if the choice is made not to take definitive action. And together, we are trying to realize a vision that all of our patients can live their best lives incontinence-free, catheter-free, chemical-free. so that they can be the best version of themselves, the best fathers, sons, husbands, coworkers, bosses, to positively impact their personal, professional, community, and global relationships. And we can do that by 3 mandates: preserve bladder health, prevent late-stage disease, and end the polypharmacy epidemic.
You spoke about this a little bit earlier. You were using that analogy of going to the emergency room and seeing these patients with benign prostatic hyperplasia on maybe single agent therapy, maybe multiple agent therapy. Maybe talk a little bit about the MVP manifesto, which really outlines a more of a bladder-centric approach to BPH, and maybe talk about how that maybe differs from sort of the traditional way that we've looked at managing men with BPH or bladder outlet obstruction symptoms.
I think a very important distinction is it's not different. We're evolving forward. In general, right, we're all human beings, but actually we're human becomings. And we're all part of this process of evolution, as well as how we manage these BPH, BPO scenarios. And now we're seeing this evolution from a symptom-based, prostate-centric approach to a data-first, pro-diagnostic, bladder-centric paradigm. And it really comes down to very simple conversations that we can have with our patients. Hey, Mr. Smith, there are only 2 major organs you can't transplant: your brain and your bladder. So we need to take care of it. The heart's a muscle that pumps blood. The bladder's a muscle that pumps urine through that prostate that starts off about the size of a golf ball, but in the shape of a donut. For all you young urologists, leave the walnut alone. It's a healthy nut. Let's just appreciate it for what it is. And let's just call the prostate what it is. Its shape is a donut. Because, Mr. Smith, as that prostate gets bigger, that donut hole is going to get tighter. And as a result, there's actually 5 stages to your bladder health. The first stage is, as that donut hole gets tighter, that bladder has to squeeze through a tighter hole and things are going to slow down. In stage 2, that muscle now is going to work harder. 5 years, 10 years, 15 years, squeezing urine through that tight hole. It's going to quiver. It's going to struggle. It's going to become overactive. Frequency, urgency, nocturia. And in stage 3, your bladder can then act out like a rebellious child if you don't take care of it. It'll squeeze without permission, causing you to leak down your leg. And if you really don't take care of it, just like your heart can have a heart attack, your bladder can suddenly stop working and you show up in the emergency room needing a catheter. And then just like the heart can go into heart failure, the bladder can go into bladder failure, which might require lifelong catheterization. Worst case scenario, Mr. Smith, your heart can still always be transplanted. The bladder is not so lucky. So this is something we need to address, and we can do that with data. And so you can see that this is just an evolution very naturally from symptom-based, prostate-centric to let's talk about the bladder because it's a precious, solitary end organ that's not replaceable. And as a result, we're big advocates of now evolving shared decision-making to what we call 3.0. It's no longer just patient, provider, and healthcare system, but we want the bladder to be able to have a seat at the table of shared decision-making as an equal stakeholder, equal partner with equal say, so at least its preferences and values are factored in. And we can see that even with prostate cancer shared decision-making. What's the status of detrusor function when you're considering radiation therapy if they already have stage 3 urgency incontinence, right? How do we decipher if they're incontinence post-prostatectomy? Is it maybe mixed incontinence because they actually had urge incontinence as well as sphincter intrinsic deficiency causing stress incontinence? And so that's how we're trying to use language, common, plain-spoken language, to evolve forward this conversation towards bladder health.
Talk about this concept of polypharmacy and late stage disease, and maybe talk a little bit about the concept and the thought process of man versus prostate and the approach and sort of combating, I think, what is sort of almost an epidemic among the healthcare community, which is patients coming in with medicine, more medicine, higher doses of medicine, and then simply adding to their cadre that they're coming in with. Maybe talk about that a little bit.
I think we all feel in the community, primary care, academics, we've kind of developed a bad habit. Mr. Smith, you got a problem, take a drug, still got a problem, another drug, another problem, add a higher dose. If we look at the data published 2021, looking at 3 million patient lives, 24 studies, the relative risk of mortality increases dramatically with polypharmacy, up to 28% when they're on 5 or more medications, up to 44% when patients are 10 or more medications. We need to start to understand why is that happening. And I think part of it, at least within the world of male LUTs, BPH, BPO, we have the ability to look at BPH meds and recognize that they are temporizing measures. They buy us time to get the data we need to make good decisions. They are not treating measures. Something that's very important, man versus prostate, we are not anti-drug. We're just understanding how do we judiciously use it. A good example, Defender Rodrigo Gonzalez talks about brain tumors. We give Tylenol, ibuprofen for headaches, but that's just managing symptoms. It's not treating the brain tumor. Medications can be treating, like antibiotics for sepsis. But in this condition, we need to recognize that we're using medications effectively and judiciously as temporizing measures, as both short-term and long-term management strategies. But that BPH medications for a mechanical problem doesn't make sense. Mechanical obstruction, like UPJ obstruction, coronary obstruction, deserves a mechanical solution. Chemicals are not a mechanical solution. And I think it really speaks to one of the biggest misconceptions out there. When those patients come in, or you tell your neighbor, hey, yeah, they're treating my problem with drugs. They're not treating it. They're managing it. And men are notorious for being unreliable witnesses to their bladders. And they will let those bladders die unknowingly. And it's our job to say, yeah, you may think you're fine, but maybe your bladder isn't. Let's get the data on the table and see where your body is at, where your bladder is at, and what it is saying, and what its preferences and values are, so we can factor that into shared decision-making. And so I think that's really important as we evolve forward, is recognizing that, maybe drugs, and as you and I both know, BPH drugs have many side effects, whether it's post-finasteride syndrome, and maybe they're actually not minimally invasive. Maybe they're maximally invasive by being able to touch every single cell in their body. And this really came home to me when I had to personally take care of a family member with cancer. And when you take them to chemo every week and you see that impact on every cell in their body, their face blows up being bright red and swelling edema, and the hair, I think we all can recognize medications have their role. We honor that and respect that, but we have to understand how to use them effectively and judiciously, and understand that BPO, benign prostatic obstruction, is a mechanical problem that deserves a mechanical solution when warranted.
Talk a little bit about what's next for the man versus prostate movement. New initiatives, collaborations. What's on the horizon?
This is an exciting time, and it's really, to see the next 5 years, we're going to have to use technology, right? So the website's building up at manversusprostate.com. BPH 360 podcast will hopefully launch next year. We've really started to look at language and provide communication tool for community urologists, specifically now the IBPSS, the International Bladder Prostate Symptom Score. I'm not sure, have you heard much about this? Or
No, I have not.
So now it's been translated into 8 languages: Chinese, Italian, Greek, German, Spanish, Portuguese, Urdu, Pashto, and this morning, Korean. What we've done is we've taken for community urologists, we need everything on just a single page. We needed something that could mirror the 5 stages of bladder health. We also needed to introduce the complexity that it's much more than just the prostate. So very simple things. One, just add the word bladder in the title. And it's actually not to shift towards the bladder. It's actually to say to Mr. Smith that, hey, it's much more than your prostate. And all we did is we took the IPSS questions, we kept them intact, unaltered, and we just separated them into the voiding subscore and the storage subscore. So now we can mirror stage 1, BPO, things slow down, And then stage 2, detrusor overactivity, overactive bladder. Then we added a question about urgency incontinence and retention from the ICIQ and the LURN Learn academically validated questionnaire. So now we have this mirroring stage 1, stage 2, stage 3, stage 4. We kept the quality of life question from the IPSS, and the South American Brigade and the European Brigade were very passionate about adding a question about sexual health, ejaculation and erections. Why? In many cultures, it is so hard for both the provider and the patient to bring up such a sensitive topic, whether for cultural reasons, language barriers, as well as men. Every day we put on this armor of masculinity. And it really is a burden to have them take it off and engage and ignite into that shared decision-making process. So that's a big one. Our third book hopefully will come out next year talking about the duality of deobstruction. We want urologists to think about deobstruction with either a fractional approach or a maximal approach, depending on your low, medium, or high income healthcare system resources. It's going to be different, right? Here in America, we got aquablation. Bravo. Awesome technology. But that's not going to work in some small place in a developing nation. What's going to work for them? And some central themes of tailor the anatomy to the technology, right? And we're really pushing that when guys do, we're really trying to enhance cystoscopy to look at 4 factors. How much anterior tissue is obstructing, lateral lobe obstruction, prostatic urethral angle, and intravesical prostatic protrusion. And then the big one that's coming out is going to be screening. We're having a big push. We're hoping conversations like this. Each healthcare system needs to pick an age at which we should start screening men for bladder health. Let us allow Qmax, maximum flow rate, be the next vital sign for men. Technology's there, hardware, software for uroflowmetry in combination with symptom scores like the IBPSS. Let's start screening these men who may be at risk for bladder dysfunction, who need a bladder health baseline. And lastly, lots of other projects, AI for cystoscopy, correlating with multi-channel urodynamics, working with the EAU patient office, Dr. Van Balken, understanding shared decision-making 3.0 for diagnostic decisions, not just therapeutics. And then finally, we're now working with academics around the world. We assembled a Delphi consensus that met last month, about 80 key opinion leaders on BPH, BPO, talking about the utility of the IBPSS. So lots of different things all over the range, really trying to understand and further the dialogue about BPH, BPO.
So for urologists listening today, what's one action? What's one thing they can do to sort of become a defender of the detrusor in their own practice?
I think it's really 3 words. Ingrain them into your brain. Bladder health matters in all parts, whether your symptom scores, how you talk to your patients. Remember that bladder is not transplantable. It's solitary. It's an end organ. It's so precious. And let's work together. Start the dialogue. Join on LinkedIn. Go to the manversusprostate.com. Start continuing that dialogue within your community, your healthcare system, because together, let's go save more bladders.
That's fabulous, Wayne. It's really been my pleasure to host you. I remember we spoke about this briefly last year, and actually it's been a pleasure to sort of hear how it's developed, and obviously hear your passion for the topic. And I'm actually very much looking forward to seeing more as time goes on.
Well, I think it's going to be an exciting time. And I think that even for our generation, everyone is now thinking outside of the box, right? Thinking about prostate cancer. What is Gleason 6, right? And that dialogue, what's a cancer? Do we need to change? Is it really the quantity of Gleason 4? Like, how do we change the paradigm, re-engineer, rethink? And I think that it's so awesome to have leadership like you who are already doing that and promoting these conversations. So big thanks to you and the AUA and Corey Del Bianco.
Well, Wayne, our pleasure to have you. For our listeners, thank you for your time. Thank you for joining us. Stay tuned next week as we talk with Drs. Rena Malik and Justin Dubin about their top 10 misconceptions of sexual medicine for Sexual Health Awareness Month. Wayne, I look forward to hopefully seeing you sometime soon in person. Our pleasure in hosting you today, and I hope you have a great afternoon.
You too. Real pleasure.
This has been an AUANews Inside Tract podcast. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.